Good evening, everybody. Always a pleasure to be back in this forum after a week of hiatus. I'm going to talk today about HPV vaccination. And by this HPV vaccines, we mean three different types of vaccines. Of course, one of which is not available commercially in India as such right away. It all started way back in 2006. So the story about HPV vaccines is not something quite new. It's been there for about a good 14 odd years. It started with the Gardasil vaccine being approved by the US FDA in 2006, followed a year later by the bivalent HPV vaccine that's called the Cervarix, which was approved by the FDA a year later in 2007, and subsequently, very recently, about 6 years prior, you have the Gardasil 9, that is the 9-valent vaccine. Now, why this is very important, and at least from the surgeon's perspective, why we should know about it, is because there is a definite association with these viruses and cancers. In fact, if you see the Bible of Oncology, there is an entire chapter that is associated with viruses and cancer, and this forms a very important part. The human papilloma virus forms a very important association with cancer. There are vaccines that are actually commercially available even today. Across the shelf, you can purchase these vaccines. They're primarily meant for young girls and adolescents, although the implications are much different for men as well.
Dilator કાઢેલા ને એમ્પ્લાસ dilator rod એમાં હશે નહીં એસિડ મોટો પીસીને લે હા મીડિયમ પીસીને અને એક URS જાઓ દિનેશભાઈ दोनों को डालो पुश करो रात को खाली करा लो.
Yeah, I think there's some disturbance there. I could set up. So, and of course, as usual, there is a lot of confusion in the air in terms of surgeons and non-surgeons as such, when we should sort of give these vaccines, whether they are actually cancer prevention vaccines, what are the side effects, if any, and what are the safety concerns, and what is it that is there in a surgeon or more particularly in an oncologist for this. So the layout of my talk will be thus. We will talk about the association of the human papilloma virus and cancer. Implications largely in cervical cancers, but there are also a lot of implications in the non-cervical cancers. But there is, in carcinoma of cervix, you have a very, very strong association, and we would see the different associations of the virus with other cancers as well. Of course, we will talk about whatever the HPV vaccination strategies, the commercially available vaccines, and the trials and evidences that surround it, and also a little bit of the future perspectives. The human papilloma virus is actually a double-stranded DNA virus. About 200 genotypes are there, belonging to about 49 species, and about 30 to 40 types of genotypes are actually infect the human genital tract. What is very important to note that 80% of the women, and we must understand that women are 10 times more common, or the infection is more common in women than in men. Close to 80% of the women would actually acquire the infection at some point of time in their lifetime, and more than 90% of them actually clear it off. So the vast majority of the women who develop the infection, it's absolutely not much of a problem. The problem occurs in only the 10% of the women who fail to clear it off. The virus becomes persistent, and the persistent HPV infection is what is troublesome. Based on the genotypes, we can divide the HPV into a low risk. You can triage into a low risk HPV type, 6 and 11, or the high risk types, and most important is 16 and 18. And you have various classes of these viruses that are important. And 6 different cancers and its pre-cancers are associated with this. If you find the association with cervical cancers is close to 100%, and that's why the association is very robust in case of cervical cancers. In case of oropharyngeal cancers, where the association seems to be increasing worldwide, or close to 300% increase in the oropharyngeal cancers worldwide, the association is close to around 35%, and varying degrees of associations from 40 to 80% or 90% from the benign vaginal, vulval, and the anal cancers. All in all, less than 5% or 4.8% of all cancers can be attributable to the human papilloma virus infection. And what constitutes a vulnerable population? So this is very important for us to understand. the people's immunity, if it's compromised to some extent, especially the HIV positive patients, patients who have received solid organ transplantation, autoimmune disease patients, these form a really vulnerable group for the HPV associated infection, and more so the persistent infections. Very briefly into the cervical cancers, the burden is, of course, it's the fourth most common cause of diagnosed cancer and deaths. 570,000 cases worldwide and about 311,000 deaths. Second leading cause of cancer in women, a fifth of the cancers in terms of mortality is because of the cervical cancers, and this is the incidence and deaths in India as per the Globocon 2018 data. Over the years, what has happened is the cervical cancers have become a global health problem. And despite the fact that we have got in some countries at least organized screening programs, or the potential for organized screening programs are there, potential for prevention is definitely there. And more recently, we've got the HPV vaccinations that we briefly discussed. Now, if you see the global trends, it is slightly different in the developed countries vis-a-vis the low or middle income countries. The developed countries has witnessed a marked decline in the incidence and mortality of cervical cancers, whereas there is a slightly higher incidence of incidence and mortality in the low middle income countries. Now, India is also one of the countries that falls under the LMIC bracket, so there is no universal screening program per se. There is a low coverage of the targeted screening populations that happens here. And more often than not, a lot of these centers run opportunistic screening programs, and a lot of these opportunistic screening programs, although they tend to pick up some amount of pre-cancers, they don't really make a dent at the national level in terms of reducing the mortality of cervical cancers. So of course we need to know that there is a need for cervical cancer screening, and I would recommend all the trainees to read this paper of Wilson and Jungner's criteria, described way back in 1968 and still holds good, very true even now. In fact, the benchmarks for screening, and there are about 10 tenets of screening, and I don't really want to go into the details because that will digress with the present topic, but it is important to throw things into perspective to understand some of the tenets of screening. The tenets of screening have been largely successful in the implementation of screening for cervical, breast, colorectal, and lung cancers. Cervical cancers, the ideal prototype, one of it is being an important national health problem, and a long latent period which is there in cervical cancers because of the association of HPV. As I said, a persistent HPV infection over years, maybe close to a decade or more, will sort of cause ultimately in some patients to cervical cancers. And the Adyar has actually classified human papillomavirus as a group 1 carcinogen. Now, very briefly, there are two other approaches apart from the HPV testing, and to make things in perspective, I just want to very breezily allude to these two tests. The Pap smear, which is very commonly known, actually it's called the papillocytology, it's been there since 1950s. The visual inspection of acetic acid is also very important. So it's very important to briefly understand about these two tests before proceeding to the HPV test. The Pap smear was a very rare success story. In fact, nations that introduced cervical cancer screening through the Pap smear reduced its incidence by around 50 to 80%. However, there are still some issues with Pap smear. Low sensitivity is there, and in the Athena trial, a third of the cervical cancer patients actually had a normal Pap smear. So it's not that Pap smear has got not issues, but despite this, about a 50 to 80% of mortality reduction happened in the developed countries. There are different issues of Pap smear in the low-income countries and the high-income countries. It's very important for us to understand. In terms of the high-income countries, the reduction in mortality has reached a plateau. So beyond that, there will be absolutely no reduction in mortality. But in the low-income countries, because of the lack of presence of a high-impact or a high-quality Pap program, the amount of success stories that the high-income countries witnessed is not something that we are seeing in the low-income countries. So there's something that is very important for us to differentiate the difference in the success rates and stories between the high and the low-income countries. So in countries like India, what is happening is Pap smear, although it's being used sparingly in some centers, definitely not as a major screening tool. What is more popular is screening by vinegar or this acetic acid, a visual inspection of acetic acid in villi. And the very fact is that it can be done at the field by primary health worker and doesn't really require a great laboratory infrastructure, which a pap smear receives. In fact, if the results are readily obtained, there is something called as a see and treat strategy, where the community health worker can actually see and treat the women who are identified as positive by visual inspection of acetic acid. In fact, India must be proud because two of the largest randomized controlled trials when it comes to VIA application in cervical cancer screening are from India. Shankar Narayan's publication in 2007 and Dr. Shastri's publication from the Tata Memorial, both of them showing reduction in mortality with the application of VIA in cervical cancer incidence up to 25 to 35% decrease in the mortality. This is the VIA approach. I don't really want to go to the details, but essentially triaging a woman who is negative, we can follow up. Positive, you refer for a colposcopy or see and treat. Of course, there are certain notable issues of VIA which preclude it from being used as a routine in, and a large of the high-income countries don't use the VIA. So as a result of the two other issues with PAP, the PAP not making a dent in the mortality in the low-income countries and the VIA not being robust enough test, we needed a more objective test, and that's a molecular test of HPV. So therein comes the HPV story, and as I said, in cervical cancers, there is a near 100% association with the human papilloma virus in cervical cancers, and that's why it is largely or immensely popular. The issues with the cervical cancer or the human papilloma virus testing in cervical cancers is that these tests are very much reproducible with very high negative predictive rates. And if a woman is negative for human papilloma virus, you can be rest assured that she will never develop a human papilloma cervical cancer in the next 5 years, or at least possibly the next 10 years. So such is the high negative predictive value of the human papilloma virus test. And we have abundant RCT evidence to show that HPV testing can, or cervical cancer screening by HPV testing, can reduce the incidence by around 60 to 70% when compared to cytology alone. The worldwide practices, again, it is all resource stratified. In low resource countries like India, we have the visual inspection of acetic acid, whereas in the high resource settings, there is a trend towards PAP testing at 25 years onwards, or what is called as a co-testing approach, which is extremely popular in the US, and also in certain other countries of the world, they use human papilloma virus testing as a sole testing for cervical cancer detection. These are some of the complex algorithms as to what a testing and a co-testing actually does. So let's actually breeze into the role of actually human papilloma virus in the non-cervical cancers, that is in the head and neck cancers. Unlike the cervical cancers, the association of human papilloma virus in head and neck cancers is much different. In fact, it is more commonly or preferentially associated with oropharyngeal cancers. There are a lot of studies that say that the association with oral cancers and laryngeal and hypopharyngeal cancers are also there, but then the robust association of human papilloma virus is with the oropharyngeal cancers. The rates vary from about 20%, and that's something in the published Indian literature. Indian data holds about 20% of the incidence of association of oropharyngeal cancers with the human papilloma virus, whereas the association in the Western countries, wherein it's a major public health problem, is close to about 80%. In fact, I'm told that close to 50% of any new head and neck cancer that occurs in the West is because of oropharyngeal cancer associated with human papilloma virus. So much so that the present TNM staging for oropharyngeal cancers, we have a separate staging for oropharyngeal cancers that are associated with the TNM. And of course, it's more important than the diagnostic implication, the prognostic relevance in these cancers. And also for the matter of carcinoma unknown primary, which we had discussed in a webinar much earlier, and this webinar is available at YouTube. So in these cancers as well, there is an association with human papilloma virus. That is, if a patient presents with a lymph node that is HPV positive or P16 positive, you can take that as a carcinoma of the oropharynx. So what's important in head and neck cancers vis-a-vis the cervical cancer is the association of HPV and one virus, the implications in cervix and head and neck are totally different. In case of head and neck cancers, if you have a positive patient with human papillomavirus, and the incidence actually, as I said, is increasing worldwide. The age is less, socioeconomic status are slightly higher. The association with tobacco and alcohol is slightly lesser, but of course, there is an important confounding factor, and that's why there is an intermediate group of patients who are HPV positive and smokers. The prognosis seems to be slightly intermediate. Some of these tumors have very small tumor sizes. The nodal status is actually larger and cystic. So it's very important for us to understand it from that perspective. It has very different molecular aberrations associated with it. And the most important aspect of it is these tumors do very well. Despite what treatment you give them, chemotherapy or radiation therapy or surgery in the form of TORS, that is the transoral robotic surgery for the oropharynx, these tumors do wonderfully well. So much so that a lot of work is going on de-escalation strategies, which are of course not that successful. But the fact remains that these cancers, the head and neck cancers that are associated with HPV or the human papillomavirus, are prognostically much better. So the association with the diagnosis may be very less, maybe around about 20 to 80%, as I said. But the more important relevance is prognostic in head and neck cancers. And we have mentioned this in an article which we did in 2012, and very recently the guidelines in a couple of years back, collating all the Indian data, wherein we have talked about the various detection of HPV in cervical cancers and also mainly in the oropharyngeal cancers, where it is mainly by P16 immunohistochemistry rather than any other molecular test, because that is something that is universally available. And as I said, the prognostic implication of oropharyngeal cancers being different. When it comes to other cancers, as I said, about 40% of the vulval cancers to around 90% of the anal cancers are associated with HPV. So the association of HPV is not just for the cervical and the oropharyngeal cancers, but a good 45 to 90% of the penile, vaginal, vulval, and anal cancers, or the reproductive tract cancers, are associated with human papillomavirus infection. So what we know is that we don't really have robust data in the non-cervical cancer, at least the impact of vaccination, but we definitely know that theoretically, and there are numerous publications to say that the human papillomavirus vaccine can inhibit the oropharyngeal cancers. But definitely we need more data to suggest any association with the oral, penile, anal, and the vulval cancers. So the implications of HPV vaccination is manifold. It is there primarily in the cervical cancers. It is also there in many other cancers. So when we talk about HPV vaccination, and that's the meat part of the talk, we talk as a prophylactic vaccine. There is something called as a therapeutic vaccine, which I will try to briefly allude to the end part of my talk. So by doing this prophylactic vaccine, we're trying to prevent cancers. And that's the motto of the HPV vaccination. If you see, the primary aim is to prevent cancer, and the robust evidence is there to prevent cervical cancers. In fact, if you see, a lot of these clinical trials, the primary efficacy endpoint is actually CIN, or cervical intraepithelial cancers, and not cervical cancers per se. And this is something that purists would sort of say that, the evidence that it prevents cervical cancers is not much there. So the evidence that it prevents cervical cancers is more by a mathematical modeling, whereas the actual evidence is that it prevents the occurrence of cervical precancers, that is the cervical intraepithelial cancers. As I said, we briefly discussed three different types of vaccines: the bivalent Cervarix, the Gardasil vaccine, which comes as a quadrivalent and a 9-valent vaccine. And I've described briefly the doses, which are pretty much same. Three vaccines, the schedules, 3 schedules, 01 sex wise for the Gardasil 9 vaccine as well. And the protection for cervical cancers highest with the Gardasil 9-valent vaccines, 90%, whereas the 2-valent vaccines, that is the 16 and 18 alone, would give up to 70%. So in all, if one takes one of these vaccines, you can be rest assured that the protection rate is in the range of at least 70% to maximum around 90%. As I said, primarily cervical cancers, but It is also important that it also prevents other cancers, as I said, especially there is a lot of evidence. There is some evolving evidence, rather, to say that it can prevent the vulval and the vaginal cancers as well. And what's more important, it must be administered to individuals prior to the onset of sexual activity for vaccines and the trials. And I must tell you the importance of these trials. The Patricia trial for the bivalent vaccines, the future 1 and 2 trials, these are very important trials, landmark trials, which I would urge you to actually go about and read. The nanovalent or 9-valent Gardasil 9 is licensed, but it's not available in India. All these vaccines are against the virus-like particles. And Cervarix gives up to 100% of protection against HPV-16 and close to about 93% against HPV-18. Mind you, despite being a bivalent vaccine, this 2-valent vaccine has got a cross protection with 4 other breeds, HPV 31 and 45 more specifically, in the range of about 80% protection or cross protection. On the other hand, I think Gardasil and Gardasil 9, they have very high efficacy against both these viruses, 100% efficacy against CIN2. And also, because Gardasil 9 actually has a lot of other the benign variants like the 6 and 11, which are mainly implicated in the occurrence of anogenital warts, it is also important in the prevention of vaginal, vulvar, and anal dysplasias and warts as well. With regards to safety of these vaccines, I think globally at least 270 million doses have been administered globally to the young men and women worldwide, and there has been no major safety issues. Excellent safety data, no serious adverse events in terms of autoimmunity, neurological, or various venous thromboembolic side effects. There were certain unfounded concerns, at least definitely in India and some parts of the country, but then more or less, I think some investigations have shown that these concerns are unfounded and the vaccine is pretty much safe. If you see the worldwide trends, 60 countries the world over have actually integrated the human papillomavirus into the national immunization programs. But ironically, what is happening is most of these countries are the high-income countries. I told you that the lot of burden or the increasing incidence and mortality happens in the low-income countries. So what's happening is paradoxically, the high-income countries are getting more and more vaccinated, whereas in actual practice, it is the low and the middle-income countries that are actually to sort of have their women and have their young girls and boys vaccinated in an attempt to reduce the burden of these cancers. And at least definitely it is the costs in these countries which are playing a major role in preventing it from getting included in the immunization schedules. Any global program or a national program would actually aim at having around 30% coverage, and there is a tendency for herd immunity, and we are hearing it a lot in the days of COVID-19, whether it will come or not, how much it matters, how much the T-cell responses matters is something that we don't really know. But at least in terms of human papillomavirus, we know that the herd immunity strategy really works well. So what they try to do is they cover around 60% of the population, and that's been successful in certain countries like Australia, Denmark, and Sweden, where about 60% of the 10 to 20-year-old girls are actually vaccinated, or rather across gender. In fact, males and females both are vaccinated in some of these countries. However, in the low middle income countries, I think the rates are low as 1%, but certain countries do well, like Bhutan and Rwanda, despite being low income countries, they do well. There was a study by Banerjee in BMJ quite a decade earlier that said that the coverage in India is also very, very patchy and sketchy. 70% coverage in certain urban areas, whereas pathetically low at 2% in certain rural parts of India as well. So the World Health Organization has come up with a strategic framework, especially for the southeastern region. It says that you must initially have a health promotion program and primarily target young girls 9 to 18 and also males as well. You have a 3-dose or a 2-dose schedule. And the National Technical Advisory Group, that is for the Government of India, has actually very strongly recommended for the human papillomavirus and to be included in the universal immunization program. The Association of Gynecology, in fact, the more of pediatricians and gynecologists which are actually prescribing or having them imparted in some of their recommendations, although it's not really a part in the immunization schedules. What it says is that young woman, or woman rather, any age between, the target age actually is 9 to 14 years, but you could give any woman between the ages up to 45 years as well. If you're giving it for a girl that is less than 15 years, 2 doses at the interval of 6 months will suffice. But if you're starting the immunization for a girl, or a boy for that matter, again more than 15 years, then they say you have to have 3 doses. And even in immunocompromised patients or patients who are of sexual assault survivors, they say that you must give them at least 3 doses. Again, it's also pretty much okay to give it for an older woman who may have had an onset of sexual activity as well. They say that it could be protective for them as well. In fact, there was some window of opportunity trials, like a randomized controlled trial in India, being stopped abruptly because of certain agencies sort of calling for the stoppage, and in which what happened was certain girls received 1 dose or a single dose of vaccination, and you could find the immunogenicity in these girls as well. So there is a very promising strategy that instead of the traditional 3-dose schedule, whether a 2-dose or a 1-dose schedule would actually be good enough for these women. But of course, these are all investigations. The actual recommendation is for the 3-dose schedule, and there are a lot of trials that are going on to test 3 versus 2 versus 1-dose schedule in terms of reaching the immunogenicity. With regards to pregnancy and lactation, it's not recommended per se in pregnancy, although there are some safety data that is there. As I said, that's why in case somebody gives it to a girl or a young lady who is pregnant, also need not worry much, because there are certain safety data issues which have been there. And as I said, not contraindicated in lactation. So it's a pretty much safe. And we must see that majority of these drugs or these vaccines are pretty much safe in the pregnant and the lactation women as well. Now coming to the interesting concept of male vaccination. We talked so much about cervical cancers, and obviously women do develop these cancers, but we did talk about oropharyngeal cancers and other reproductive cancers, how efficacious or how judicious it would be to include males in the vaccination strategies. I really alluded to that females are about 10 times more prone to HPV associated cancers than males. And the heterosexual males, they sort of hypothesize that some of these heterosexual males will be protected by the concept of herd immunity if close to around 30 to 60% of the women are vaccinated. So that's why the debate was whether to vaccinate the men for these vaccines or the boys for these vaccines or not. But then again, the problem is that in low middle income countries, where the coverage of the vaccine is going to be very less, vaccinating only the girls alone and leaving the boys per se may not actually give you the herd immunity. And also, it's definitely in the homosexual population, it's not going to be worthwhile as well. So that's the reason why various countries in the world have actually started advocating human papillomavirus to be given for the young boys and the males as well. So again, I think if you see the worldwide data licensed in US for boys in 2009 itself, 11 to 21 years, and catch up to 26 years of age. As I said, that it protects also against anogenital warts, also especially the Gardasil vaccine, that is a quadrivalent vaccine. And of course, as I said, that it has the potential to prevent the other precancers, genital warts and penile cancers, and also the oropharyngeal cancers that occur in the women. And this is predominantly by the Gardasil vaccine. But in India, if you see, the licensing is only for the girls. So although you have robust data to say that it is safe in males, and there is a scientific argument to sort of vaccinate the males as well, but in India, the HPV vaccination is only for the girls, and they remain the top priority, and it's not vaccinated. So mind you, if you are in India, you have to play by the rule of the land, and there is the rules that says that the licensing is only for the girls in the particular target age, preferably between 9 to 14, can be 14 to 16, attachment up to 26 years selectively. It's very important that it's a national immunization program, so you must engage all the stakeholders. As I said, a lot of confusion in the air with regards to some of the issues concerning vaccination, especially when it comes to parents vaccinating their young girls, at least in India, young boys and girls worldwide. There is a lot of concern about issues of safety and efficacy and all other issues. And I think it's very important for all of us. In fact, this talk is meant for even the common community as well. It's very important that common people in the community and public are aware of these cancers. And the surgeon community as such should be more aware of this, because we are going to deal with some of these cancers. Cervical cancers, obviously, of course, gynecologists will be more often dealing with that. But at least when it comes to other cancers like the oropharyngeal cancers, the penile cancers, the anal cancers, the vulval and the vaginal cancers, these are cancers which many of the other surgeons' colleagues may actually be dealing with. So we must be aware of the implications of association of HPV with cancers and the possible protection that a HPV vaccination can afford to some of these cancers. Again, it's, as I said, it's very important that we must undertake, at least any society that wishes to undertake a national schedule for immunization should have the stakeholders' participation and involvement. It's important to involve them in preferably a school-based programs, and some of them have shown to have a very resounding evidence. There are certain future vaccines as well. As I said, we have three vaccines: the bivalent and the quadrivalent, which is licensed in India; the 9-valent, which is licensed but not available. There are a couple of other vaccines, and there is also an Indian vaccine that's going to be available, and possibly in a couple of years' time. Maybe by late next year, we would have an Indian quadrivalent human papillomavirus vaccines. It's undergoing tests, and if that comes, I think the issues of costs, which were a major deterrent of usage of vaccines universally across the population, was a challenge. I'm sure the Indian vaccines, and I hope that this vaccine should, at least the COVID vaccine, should come much earlier than the human papillomavirus, at least the Indian version of it. As I said, that the window of opportunity trials has said that the single-dose vaccine schedules may also be good, and we would have some data about the long-term follow-up of some of the Indian women in the randomized controlled trial that got abruptly stopped, showing that the single-dose vaccine schedules, the immunogenicity, if it's good enough, then I think it would be a great cost-cutting actually. So the other thing, as I said, is at least in terms of cervical cancers, these vaccines at max would protect around 70 to 90% of the cervical cancers. And 10% of the women would, even then, even the vaccinated woman would actually get cervical cancer. So 10%. So by giving this prophylactic vaccine, you're tending to prevent or potentially prevent rather 90% of the cancers. 10% of the women vaccinated would still get the cancers because of some other sort of genotypes of human papillomavirus. So why this is important is that even though a woman is getting, or a girl or a boy is getting the vaccine, they must be subjected to the routine screening protocols of at least the cervical cancers, and of course the other cancers like the oropharyngeal, penile, anal, vulval, and vaginal don't really have any screening recommendations. The screening recommendations are primarily there for cervical cancers. So the young woman who has been vaccinated should sort of continue the screening recommendations of that country, even despite receiving the vaccination. And this screening should be based on a HPV-based screening. So as I said, there are three modes of screening: the Pap smear, the VIA, and the human papillomavirus. So it's actually recommended that because of the association of 100% association of HPV with the cervical cancers, that such of these women who are participating or who are recipients of the human papillomavirus actually get your screening cervical cancer by HPV screening. So what we talked about till this now, and this is the last two slides of my talk, is about the prophylactic vaccines. But in cancers, there is also some element of a curative vaccine. What if a woman of actual CIN 2 or 3 comes, can we administer this vaccine as a therapeutic vaccine? And this is something that is a fascinating research that is going on. There are many candidates, vaccine candidates rather, that are available: the bacterial, the viral vector, the peptides, nucleic acids, cell-based A lot of vaccines in the pipeline which were being tried in various trials. In fact, there was a randomized controlled trial also which was ongoing and which is ongoing, some of them. And there is also a lot of buzz about immunotherapy. So a combination of PD-L1 and human therapeutic vaccines is something that is something that is seen. But unfortunately, none of these candidates have actually been able to completely regress the human papilloma-associated cancer. So there have been wonderful or reasonable success stories, I must say, but these are early days. But that's why the way the world is going. So of course, the focus would be on prevention, giving it as a primary prophylactic vaccine, but then there are a lot of scope for it to develop as a potential therapeutic vaccine also. So, to conclude, I say that definitely human papillomavirus vaccination significantly decreases human papillomavirus infection and also HPV-related diseases. Diseases, why I say because it's not always cancers. It could be the anogenital warts and other warts. Human papillomavirus can affect head to any part of the body, can have numerous manifestations, mucocutaneous manifestations. You could have many other 6 different precancers and cancers as well. So definitely a vaccination strategy against this will sort of protect the woman against these viruses. And if you introduce it as a pan-gender vaccination, that is, if you are introducing it for both men and women, but I must admit that in India at presently the licensing is only for the girls, but at least in terms of scientific evidence, it shows that administering it for both the genders, the boys and the girls, can actually reduce significantly the burden of human papillomavirus infection and possibly human papillomavirus related disease, including cancers. So some of these data, of course, we have published. It's available on net, at least with regards to cervical cancer. So anybody who is there, at least the focus of cervical cancer part of it has been covered in one of these publications. It's not yet published, but it's just available online. So anybody who's just interested can glance through this article, which is available in the Spring Journal. So once again, I would like to thank Dr. Patta for the opportunity and would be open to any comments or questions. I know it's a slightly niche topic, but I thought I would give this forum slightly difficult sort of talks to sort of get some younger brains tickling. Thank you, sir, once again for the opportunity.
Thanks once again, Arvind, for an interesting topic. Now, any questions from the audience on this particular topic? Just come up and ask Dr. Arvind. Anyone has got any questions or comments to make? I think this is a very, very unusual topic for the surgical audience. So I think it's all information and thanks. Thank you so much for.
Some of them are sending it in private chats, but I think so. I think it's because it's a slightly niche topic. I think
That's
difficult for people to understand.
Thanks again, Arvind. Thanks for the effort.
Thank you, sir.
I'll see you again.
Yeah, sure. My pleasure. Sir. Thank you.